my name's Sandra Smith, and I'm a public advisor. Yes, Mark, you okay?
I'm going to have to see, because I've got to see the screens.
Right. Okay, so I'm going to talk about sort of accident and emergency bypass pathways for people with special palliative care needs. And I've learned this morning that we don't use the word accident anymore, we use emergency department. So that's a new one for me. Okay, so the aims of this and the overview that I'm going to be looking at is, what is special palliative care, and why this research project, and the aims of this potential project, priorities, and we're going to do some statistics, which we always do, and I've got some views, some videos from frontline staff, and then we're going to have a group discussion. So I hope that we've all got a mixture of all different people on all the different tables so we can have some great feedback. So what I'm going to say is why this research. So I actually sit on the Cheshire and Merseyside Palliative Care and End of Life Programme Board. I'm also on the Special Palliative Care Review for St Helens and Knowsley. And I support lots of people that are end of life, particularly with progressive terminal diseases such as motor neuron disease. I'm not a researcher. I've got a title of a public advisor, but I actually say I'm a person with lived experience. And I have... Sorry?
You are a researcher, you're a public researcher.
I'm a public researcher. Thank you for the compliment, Mark.
Oh, you are.
So I hear comments from sort of family and carers and their perspectives of what A&E is, or what they've experienced in A&E. And...
Sorry, just keep track of that. Keep going.
Keep going. Thank you, Mark. So some of the comments that they say is, I don't want to ring an ambulance because I don't want my loved one to end up in A&E on a trolley and maybe die on a corridor. I don't want them to be in A&E for a long time when they're at end of life. And I've seen on, I don't think we can even use this word now, Twitter or X, but they say we've seen on Twitter or X that A&E is extremely busy and don't come to A&E. And that obviously then causes distress for family and carers. Or it's Friday and all be full of all drunkards. And one of the things that has actually come out from some of these comments is about the mental health of the family and carers. And I always have this saying of, we have to live well, but we also have to die well. And if family and carers have a loved one that's had a bad death, then it can affect their mental health, which can also then have a knock-on effect for bereavement services. So this is all about costings. Okay. So we're talking about sort of special palliative care rather than palliative care, because the way I look at palliative care is that palliative care comes from a diagnosis. So it's through that journey of somebody's terminal disease. So special palliative care, as we said, is defined as an active, total care of patients with progressive, advanced diseases and their families and carers, it should say. And care is provided by a multidisciplinary team. And they've undergone this recognised training. And the aim is to provide physical, psychological, social and spiritual support. And this was commissioned in 2012, so maybe it needs to be re-looked at. So, the aims of this project. So it's to look at service provision around end-of-life pathways. But we're talking about adults at end of life. And again, needing special palliative care to bypass, we'll drop the accident, the emergency departments. So it's also investigating the current and the future demands on the special palliative care services and investigating cost effectiveness for all the people from the ICBs that want to look at how much it's going to cost and how much they're going to save. But for me, it's about patient outcomes and the pathways to prevent these people in special palliative care being admitted to A&E. And we also have to look at the family, the carers, and everything has to be at the heart of the person. So priorities. again, it's responding to the needs and the resources of the NHS. And I know I can't comment about resources in the NHS at the moment. And the change in preferences. And we talk about advanced care planning and the place of death where people want to die. And for me, it's about reducing these A&E admissions and a seamless care for patients at their end of life. And again, their family and carers. And it should be equitable. Access to care should be equitable. But we've got to have the right workforce, the capacity, and we're going to look at their future needs. And again, we're talking about a couple of statistics. And I can't see them from here because I'm not very blind. But we're talking about the population growth. And we're talking about, you know, an increase of 7,000 people in 2030. That's going to be over the age of 65. And we've already talked about comorbidities and whether those people will need special palliative care. And that's just within Knowsley and St Helens. And again, place of death. The most common place of death is in hospitals. And that's followed by our person's home. And again, it's going to increase. Home deaths are going to increase, hospital deaths are going to increase. And so we need to look at pathways for best death for people. And I've got a couple of more statistics. Look at the way A&E attendances at end of life shoots up in the last 12 months of life. Now, how many of these people are under special palliative care? Got a couple of videos from health professionals that are supporting me through this project, and I work closely with them. One from the ICB and one from a hospice who actually supported me when my husband was dying from motor neuron disease and frontotemporal lobe dementia, and therefore knows about and understands my dedication to quality of living, but quality of death.
Hello, my name's Paula Powell. I've been a palliative medicine consultant since 2009, more recently a medical director at Willowbrook Hospice in Merseyside, and until the end of March this year, I was the clinical lead for palliative and end-of-life care in Cheshire and Merseyside. I know the difference it makes to patients and families that they receive high-quality specialist palliative care where they need it and when they need it, and that needs a system-wide approach. This kind of research will really make a difference in understanding how we can best respond to the needs of people who are at the end of their lives.
So Sandra's asked both Paula and I to say a few words regarding research support in relation to the work we've been doing regarding specialist palliative care services. So a bit of background, St Helens and Knowsley ICB have been working with partners across Merseycare, Wiston and Willowbrook specialist palliative care teams over the last couple of years in relation to our specialist palliative care review. This is to inform and develop our improvement plan where we feel the opportunities may lie to improve patient, carer and staff experience, and I feel like we've worked really well and very hard together during that period to get us to where we are now and really understanding what those priority areas are. So from the workshops we held with staff and engagement with patients, it was clear that out-of-hospital care and the pathways into the hospital, the whole environment, the interdependence across those pathways would really benefit from more detailed understanding to further tease out the pathway complexities and how we can continue to work together to improve the integration of those pathways in terms of supporting avoidance of A&E, but also the pathways into hospital when a person does need to go into hospital, but trying as much as possible to avoid the need to be going through A&E unless absolutely necessary, just to improve the overall experience we feel for patients, their loved ones and staff as well. So I suppose by recognising not just the capacity challenges within services, which we are also working together on, having support to research further this really complex area of care pathways and working with our already engaged clinicians and our A&E clinical nurse specialists for palliative care would really help us drive this priority forward for us sooner rather than later. And any help we can receive from the network we know would be time really well spent for our staff and patients as part of our efforts around continuous improvement. So what it would do would build on the data we've started to understand through the A&E CNS team over the past year and really help expand our research into the outer hospital environment. So thanks so much for considering us for support, which what we feel is a really significantly important area of care. So thank you.
So thank you. So as Caroline, who's from the ICB and St Helens and Knowsley, it's not just about people avoiding A&E, it's about the community services to prevent them going into A&E in the first place. It's about whether, if they arrive at hospital, bypassing A&E to appropriate wards, to appropriate services. And obviously with this ageing population, with people with special palliative care needs, it's an important area for me as a public advisor, for me as a person with lived experience. Okay. So we're going to do, for the people that are online, I think we've got a Padlet, which Pete Dixon is going to monitor. And before I go any further, I'd just like to say a thank you to Pete Dixon, who's hiding over there in the corner, because he's been a great support for me and Tony and Jenny as the co-lead for the person-centred complex care. They've been a massive support for me, and I'd just like to say a public thank you. So we're going to have a couple of scenarios. So I'd like you to have group discussions. So if we could all maybe move round to tables where we've got a mixture of all different types of people, be public advisors, ICBs, A&E, consultants, GPs, as she looks at Mark. Mm-hmm. And we want to have a discussion. We've given you 3 scenarios. So the scenario, again, is about a 38-year-old man with incurable cancer, less than 3 months to live. He's under community special palliative care team, married with 2 children, 11 and 7, and he lives in a rural location. But on a Saturday night, as we all know what A&E is like on a Saturday night, around midnight, he tells his wife he's in excruciating pain. But instead of the wife calling the community speciality team, she dials 999 for an ambulance, even though she is reluctant and afraid that he will pass away on a hospital trolley in A&E, as I mentioned previously, as she believes A&E will be busy due to the weekend. So that's the first scenario. I'll give you the questions after the third scenario. Mary, a 75-year-old lady, lives alone and has no children, and her nearest family live over 2 hours drive away, which is probably only about 5 miles away the traffic is these days. Mary's under the community special palliative care team, but in the night goes to the toilet and has a fall and breaks her hip, which we know is common in elderly with falls. Carer finds her next morning on the floor and dials 999 for an ambulance. Again, Mary is reluctant and afraid to go to hospital, as she's afraid she'll die on a trolley in A&E. And she's where she has little choice because of a broken hip. And the third scenario, this is a bit too close to home for me, but now is a 33-year-old man who lives with his partner. He has been diagnosed with bulbar motor neuron disease, which is a fast progressing form of motor neuron disease. And again, although now it is under the MND multidisciplinary team and the community speciality palliative care team, he has breathing difficulties, has non-invasive ventilation on a machine, which he uses up to 12 hours a day. He develops a cough and has difficulty breathing, and his partner is at work. So Noah, probably via an eye gauge, calls 999. So these are the next steps that we're looking at. So we're going to investigate the challenges within services, patient outcomes, service provider outcomes, and the barriers to change. So on your tables, you will have the list of the scenarios and also some of the questions on the scenarios that we want you to answer. So if you have how many minutes? 10-minute discussion, then I'll come around with the roaming mic if you have any questions. Yeah, if you could put your comments on the notepads, the post-it notes, we'll also collect them at the end. Right, ladies and gentlemen? Okay. Do we have a volunteer to go first? Neil. He just called me you.
Thanks for picking on me, Sandra. Turn the mic off as well. Okay, we kind of understood the question to be where should patients go? As in, like, is there a choice? For example, A&E could be the only choice. You know, it's contextual. If there were a palliative care crisis team, that would seem the obvious kind of option, but unfortunately funding dictates that these teams aren't there, and if they are, they probably work on a certain hours shift pattern. And coming to the question where the patients want to go, you know, it's agreed, isn't it? It's a really deeply personal decision. And it depends on many things, intersectional considerations, faith, cultural beliefs, but also the families. They may have their own deeply held negative experiences of some places, and will want to keep them at home, which could see a deterioration in, you know, their condition or whatever it is that they've just experienced. So that's where we're up to. So I'm going to pass to my next victim.
Oh, on this. Yeah, so one of the, like we were saying, one of the questions where it says, where should patients go? Meaning they physically go somewhere. In certain of these scenarios, we did wonder at midnight, where else could you go physically? Like, where could you go apart from a hospital setting? So we thought, if you're saying where should they go, as in going somewhere, and yeah, we were just kind of talking about one of the barriers being if you were trying to, it's very context dependent. Somebody could change their mind on a day-to-day, hour-to-hour basis where they want to be when this happens. Anything could happen, so it would be quite difficult to put in place like a very rigid plan that can't be deviated from, because that wouldn't be necessarily appropriate.
I think one of the answers to the question is, we were talking about the gentleman who has motor neuron disease and who has breathing issues. And maybe there could be a pathway for him to go into a respiratory ward. And then they are the people that would be looking after them. So that's just some of the ideas. We...
Thank you so much. We were talking about to have an ideal place to go, in a special place where you've got all the care for them, and they don't go to the A&E at all. They bypass the A&E, isn't it? I gather they used to have it, like a Macmillan group. And because they've got all their information, they've got their papers, they know who they are, they can care for them. Also, when you have a community multidisciplinary team to look after them, they know them. So that's another way they can go, you know, if that is set up. But the barriers is funding, isn't it? If there is no money, they can set a special place up. And that's what we should be looking at, to have a special place for these people. But if they go to an A&E, I was thinking it's a triage, because you know, the triage, if they've got the case note, they should triage the patient very quickly to where she should be, rather than lying on the bed. That's another thing we need to think about.
Thank you, Dorka.